just so everybody's aware. So good afternoon, everyone, and thank you for joining Maine Public Health Association this afternoon. I'm Heather Drake. I'm our Membership and Engagement Director, and I'm excited to be sharing the stage with the University of Maine Augusta and our co-collaboration and sponsorship of defining and addressing health-related social needs in Maine. And I'd like to extend a special thanks to our health equity member section, who has really taken the forefront in organizing, planning, and implementing today's event, which is part of our series on health equity and turning information into action. So later during today's event, we'll go into some breakout rooms and talk about how we can become action-oriented with the information that we've learned today. And if you registered yesterday, I sent out those questions in advance, and we'll share those again. And I want to send a special thank you to all of you for attending today, and especially to Drs. Byhoff and Coburn for being our presenters. So just a few housekeeping items before we begin. As I already announced, and you probably heard when you signed in, that we are recording today's webinar, and we'll make that available on our webpage. And we'll send it out to all registrants as well, in case you'd like to watch again. We do encourage you to introduce yourself in the chat, and we'll also be using the chat for questions and answers. So please feel free to put any in there. And we do ask that you stay muted until we get to the Q&A portion, and we can come off chat to do some questions too. If you're in need of closed captioning, that's also available. And if you have any problem locating it, please just let us know. And then we are doing a post assessment. So we ask that you please stay on until the end to take that post assessment, but we'll also include it in follow-up materials as well. So then our presenters today, I'm really happy and honored to have Dr. Elena Byhoff and Dr. Annie Coburn with us to talk about their work on health-related social needs. So Dr. Byhoff is an assistant professor at Tufts Medical Center and Tufts University School of Medicine. She's also a primary care physician and a health services researcher with an interest in how primary care can be leveraged as a point of entry to address social determinants of health and reduce health disparities. And then we also have Dr. Annie Coburn, who is a research professor emeritus and senior fellow at the Musty School of Public Service at the University of Southern Maine. And his research has focused on topics related to health access and insurance and rural health. So many thanks to both of you for being here. And I will turn it over to Elena to begin your presentation.
Hi, thanks. All right. Can everyone see that? All right. Well, it's really nice to be here. I'm very excited to be speaking to this kind of public health and community engaged group. I'm going to talk through some definitions and then some of my relevant research to kind of set the stage for Andy to talk through some Maine specific applications of some of the concepts I'm going to touch on. And so I just wanted to acknowledge I have some funders for some of the work I'm going to present, and I have, research takes a village. And so I have a lot of collaborators that I've worked with to kind of present some of the research findings in addition to some of the ideas that I'm going to present today. So the outline for the three things I'm going to kind of touch on. First, social determinants of health, defining terms. So I know there was a sheet sent out with like all the different kind of jargon, social needs and health disparities and so on. So I'm going to try to give my physician lens through how we talk about those and think about those in the healthcare field. And then I really wanted to focus on my kind of comparative strength of what I bring to this conversation, which is as a primary care physician, trying to push outside the box of just healthcare when thinking about health disparities and how we can better address those. And so I'm going to present to you kind of like where we are within the healthcare system and thinking through social needs from a very doctor-given lens. And then I'm going to end with some state-led innovation and community partnership models that are happening most frequently through Medicaid innovation. So I'm going to talk through some state-specific information. Unfortunately, this state is more Massachusetts than Maine because that's where I am, but I'm really excited to have this conversation and opportunity to talk to the Mainers. So social determinants of health, what are they and why do they matter? So, a picture is worth 1,000 words. So 2 pictures are worth 2,000 words. And so the WHO has a definition. Social determinants of health are where you live, work, grow up, play, age, eat your dinners, and so forth. And so I really like this map and picture. This actually came to me as a slide during the COVID pandemic. Instead of taking the T, which is the public transportation in Boston, to my hospital, I work downtown. I started driving, right? Everyone was afraid in driving during COVID or in those early days. And this like 1.1 mile trip road on my walk home, or on my drive home, really like fundamentally represented what social determinants of health are. Because social determinants of health are really about like the context and environment in which we live and the opportunities that are provided to us or not, and allow us to make choices or not for our lives and our health and all of the long-term consequences therein. So the picture on the right, so standing right behind me as I took this picture is a Boston public housing structure. Low-income housing, and then looking across the street, you see a fenced up old factory with a tree growing out of it. On the ground, you can't quite see, there's broken glass and some trash and some syringes. There's a broken pickup truck kind of sitting on the sidewalk there. And so when you think through this picture, when you like what that means about the social determinants of health, like think about the child growing up in this neighborhood. Think about walking to school every day. Think about the quality of the school and what the like actual, physical plant of that school building looks like and what the quality of education might be. What does the grocery store in this neighborhood look like? Is there a grocery store in this neighborhood? Or are you buying all of your groceries at the corner store? And what does that kind of mean for you in terms of your life choices and opportunities? And what is that trajectory when it comes to accessing health or developing chronic disease or being able to self-manage your health and healthcare? 1 mile away is this other picture of this big kind of Tudor house with a picket fence and the big, beautiful shaded leafy trees. And, thinking through like, well, what is the life of the people who live here look like? What are their choices? What are their opportunities? Where are they getting their groceries? What does the school look like in this neighborhood? When it's a nice day, are they able to go out and safely go for a walk and get some fresh air and kind of de-stress in a safe and healthy way, compared to the people who live 1.1 miles on the other side of the Greenway? And so when we think about social determinants of health, like this environment, this context, and the opportunities and choices it provides you, that's what we're talking about. And so in the medical field, if you can't put a number to it, what are you doing anyway? And so I have a lot of pictographs of like kind of like how the world of medicine has evolved in thinking through why social determinants of health actually matter and why we should be paying attention to them. So this is one of like the old school kind of how much is healthcare actually contributing to your health. So the kind of rule of thumb is 20% of what we as doctors do in the hospital, in the clinic, is actually providing you any sort of measurable health. And the other 80% is coming from somewhere else, like your environment, your choices, your socioeconomic status and activities. And so I did a deep dive to try to actually figure out where they got this 20% number from. And the answer is it was a consensus panel of experts in the early 2000s and late 90s. Wouldn't you know it? It's not actually from any real data. It's just a consensus of people who think they're smart. So essentially, we're trying to move away from this more quantitative model because it's not really kind of evidence-based into a more qualitative model that looks like this. And so I like this model because it's really conceptual and it kind of highlights the indirect factors that have to do with health outcomes and health disparities, right? And so that light green on the outside, so government policy and income and your identity and education, those are all indirectly related to health. And the mediating factors in the middle are the direct factors, right? This is a public health audience. I should not have to explain how environment like air pollution or water pollution has a direct impact on health and health outcomes, or how health behaviors like smoking or drinking or exercise has direct impact on health behaviors. The thing I like most about this model, quite frankly, is the purple in the middle, the health outcomes. In the medical field, we tend to focus a lot on kind of those biometric intermediate health outcomes. Someone's hemoglobin A1C, someone's systolic blood pressure, someone's body mass index, which we really like because we can measure them and we know if we improve them or don't improve them and make changes based on that. But I don't think in the real world that those numbers are quite as important to the public as they are to us numbers-based physicians. And so what I like about this model is it really includes kind of more holistic outcomes of measures of health. So functional status, status? Are you able to live independently and do all of the things you need to do to get yourself dressed and ready and fed? Quality of life and well-being, obviously that's an important measure to individuals. Life expectancy, mortality compared to your neighbors. So as much as I think this model is an improvement, I think it benefits from having a little bit more structure. Like there's not this amorphous interplay. Like there are things like A impacts B, impacts C, right? So government policy impacts environmental pollution, which impacts health. And so there is a movement to like get some more directionality between the relationships of direct and indirect factors. And so that brings us to the upstream downstream model of like the river of social determinants of health, where social determinants of health are considered upstream. They are the melting iceberg or snow caps on the mountain, and they flow midstream through social needs or social risks, which happen at like kind of the community and individual level. And they contribute to health disparities, as the stream enters the ocean, where medical care is delivered in hospitals, in community healthcare settings, in doctors' offices. And so I'm going to spend some time a little bit talking through this slide. I know this is a very savvy audience, so hopefully I won't waste too much of your time here, but I kind of wanted to go through like kind of conceptually social determinants of health. So upstream issues like laws and policies, as I mentioned, flow downstream. And the most important thing is to think about is how they contribute to health or not, and the need for healthcare or not. So I really wanted to start by saying social determinants of health can actually be advantageous, not just creating disadvantage. We tend to think about them as disadvantageous, but I would like to point out that my 7-year-old daughter has very advantageous social determinants of health. She lives in a home in a safe neighborhood. We have excellent public schools. She has a well-funded after-school program. There's healthy food in our refrigerator. Every time she turns on the water from the sink or the shower, she doesn't have to think twice about it being tainted or polluted or unhealthy or poisonous. We often think of social determinants of health as detrimental because negative social determinants of health contribute to disparities of opportunity as well as disparities in health. And so redlining is an example of structural racism. It was the government practice of restricting minority access to best quality houses by denying home loans. And this has led to generations of disinvestment in communities where racial and ethnic minority groups have been intentionally forced to live. And transportation policies then become layered on top of redlining policies, further exacerbating disparities between people who are constrained to live in disinvested communities and people who are not. And my favorite example of how these layers of policy contribute to health disparities is, so I actually did a fellowship in the University of Michigan. And Detroit is notoriously suffering from disinvestment, and a lot of the Black and minority communities in Detroit have been not only redlined, but also have suffered decades and decades of disinvestment, leading to tremendous disparities there. But the thing that I thought was most interesting is that Detroit became a trade center between Canada. Right across the river from Detroit is Canada. So throughout the kind of industrial revolution and all of the processing from the factories in Southeast Michigan, all of those materials were being trucked in semi-tractor trailer, 16-wheeler trucks, like across the bridge from Detroit to Canada for trade. And where were the truck routes placed? So they were placed directly through all of the formerly redlined Black and brown neighborhoods that were created by the initial redlining governmental policy in the 1940s. And so those communities had large trucks idling in traffic, barreling down the street, making the air quality worse and making it unsafe for children to play outside. And so it isn't really hard to draw the line between the redlining policy that created disinvestment and then overlaying racist transportation policy on top of it, and worse health status and lower life expectancy for people who lived in that neighborhood. And so moving kind of midstream, social needs exist more at the individual or community level. When governmental policy underinvests in housing, which is like an upstream policy, there's not enough affordable housing to go around. And what is available is unsafe or substandard, often asbestos or lead or infestations or mold. And so unsafe housing becomes a social need or a social risk. And unmet social needs have direct health consequences, and we often call them health-related social needs. And so, for example, if a family works a minimum wage that doesn't make enough money to live above the poverty line, often people are constrained in the choices that they can make where they can live. And they can live in inadequate, crowded, or unsafe housing conditions with mold or lead paint or no air conditioning or old carpets or anything like that. Often families are unable to afford heat or electricity. And so then you see high rates of asthma in the children who grow up in those homes, who show up then in doctors' offices. Another example is the idea of like food insecurity. So Boston itself does not have a lot of food deserts, but most of my work is done in collaboration with the community in Lawrence, Massachusetts, which is right on the New Hampshire border of northeastern Massachusetts, and they have a ton of food deserts. And most of the people buy their groceries in that community at bodegas or corner stores. And you can imagine you're not buying healthy, whole grain, organic, local produce at the corner store. You're buying sugar sweetened beverages, you're buying processed foods, you're buying calorie dense snacks. Which in turn in that community leads to high rates of obesity and diabetes. And so there's food insecurity and inadequate access to healthy foods, but what's showing up in our medical system is obesity, hypertension, diabetes, asthma from folks growing up in some substandard or polluted neighborhoods. And so how has our medical system evolved to treating these unmet social needs? Like, am I calling up landlords and saying you need to remove the carpeting and install some air conditioning? You need to get an exterminator to get rid of the mice. Am I calling up, Stop and Shop or Hannaford and saying, no, you need to build a new grocery store in this community because the rates of obesity and diabetes is skyrocketing? No, what I do is I prescribe medicines. I refer patients to endocrinologists. I get them in with nutritionists. And so the important thing to think about is when we talk about health disparities, it's not, this is like often a talk I give to a medical audience where there is not that intrinsic understanding that health disparities are really rooted in environmental and social context, but the misunderstanding that it's really rooted in like a fundamental difference between individuals, and that it's something in the DNA or something in the person or something in the culture that has led to these health disparities. And so it's not this intangible thing that we can't do anything about and that naturally exists, but it's what we as a society through government policy and legislation and social exclusion have done to create unfair and unjust systems. And these unjust systems lead to differences in rates of chronic disease, ability to afford medicines, and just get healthcare generally. And so those things add up to large differences in life expectancy and what we call health disparities. And so just to simplify the concept, right? So we have large governmental, organizational, structural policies that impact individuals and that seek out healthcare because they are disparately affected by these unmet social needs. So kind of moving away from these larger definitions into kind of more concrete, how is healthcare thinking through these ideas, I wanted to give a clinical vignette just to show the non-healthcare folks, like what is actually happening in doctors' offices across this country. And so this is drawn from a patient of mine. This is a real story. So the Mrs. Y, she was my patient, still is, 62 years old. She came back to see me in follow-up. She has a history of hypertension, type 2 diabetes, and obesity. I saw her just last month because she told me she was feeling dizzy. And she is back 1 month later, made a follow-up appointment. She's not feeling any better. Her blood pressure is fine. For the non-doctors in the audience, that's a good blood pressure. That's her heart rate, also fine. Orthostatics is a way to measure, are you dehydrated or are we giving you too much medicine? Are you feeling dizzy when you stand up? That test was negative. She's on one blood pressure medicine and she stopped her other blood pressure medicine, the amlodipine, at the last visit because I was worried we were giving her too much medicine. Her exam is essentially unremarkable. These are all fancy doctor words, but essentially I did a full neurological exam, a cardiovascular exam, and there was nothing obvious to me that was causing her dizziness. And so I do pull out my doctor trick when I really don't see a medical cause for what's going on. And I ask Mrs. Y, what do you think is going on? Like, I don't know. I can't explain it. Can you tell me what you think is going on? And she says to me, Dr. Byhoff, do you think it's because I'm not eating anymore? And I'm like, well, tell me more about that. And so the short answer is that Mrs. Y's grandson lost his job and couldn't afford to pay rent with his shared apartment with his roommates and moved in with Mrs. Y. And it turns out that Mrs. Y was working part-time at a call center, but was on food stamps to supplement her income. And so Mrs. Y had enough food stamps for 3 meals a day for just her and was kind of doing just fine and getting by. And her she lived in subsidized Section 8 housing. But once her 26-year-old grandson moved in and started helping her around the house and looking for a job and playing basketball with his friends, all of a sudden there wasn't enough food to go around. She didn't want to tell her grandson not to eat. And so she was just eating 1 meal a day instead of 3. And sometimes that 1 meal a day was just oatmeal and coffee in the morning. And so for those of you who might not know, this is Maine specific. I think this is kind of old data. I think this is from 2020, but I looked up the Maine specific food stamp data. So Mrs. Y, if she was living in Maine, couldn't have taken home more than a little bit more than $1,000 a month to get a max benefit of about $50 a week. So this is not a ton of money she was making, and it's not a ton of money for grocery shopping, but for Mrs. Y, it was kind of more than enough. But once she had her son in the picture, or her grandson, I'm sorry, it was no longer enough food to cover for both of them. And so, you know, how we think about this in medicine, I could have ordered a million tests. I could have gotten an EKG, I could have gotten a stress test, I could have gotten a CAT scan of her brain, all that would have been covered by insurance. Every single one of those tests would have been normal, and it would have never gotten to the root cause of why Mrs. Y was feeling dizzy. And so the real consequence of the way the medical establishment is kind of thinking about disease and thinking about health disparities is with a kind of a medical-led investigation. And it leads us to high readmissions rates in hospitals. It leads to labeling patients as non-compliant when they're not doing well on their prescribed therapy. And it kind of misses the big picture and the ability to care for patients. And so there's a large policy push from CMS, from various professional societies to really incorporate social risk screening as part of routine healthcare delivery. And so I've done a lot of work in this space, but I just wanted to touch really briefly on actually one study I did that really ties into like how recommendations are being made at the national level to think about social determinants of health screening or social risk screening in clinical care. And so that was one large paper I did, asking patients themselves how they felt about social risk screening. From the provider side, there's a lot of concern. It's not our job. We shouldn't do it. It's opening a can of worms. How are we going to fix this problem in the first place? And so what we decided to do is actually just ask patients how they felt. And this is not the only study, but a lot of these results are kind of found multiple times in multiple different clinical scenarios. So what we did is at 10 different sites across the country, we screened people with a CMS-derived accountable health community screener. It was 10 questions. And then after they completed the screener, we conducted interviews of patients to say, you know, how did it go? What would you change? What did you like? What did you didn't like? How should we do this best? And so the main themes we found when we asked patients about including social risk screening as part of their routine clinical visit, first is that it was important to do. Patients felt like it allowed them to be seen as whole people. They felt that their doctors understood them better, and they felt less seen as diagnoses and more seen as humans. Second, the patients themselves were making connections between their own social needs and their medical problems. My favorite quote from this entire study was a woman who had been in the ER 5 times in 3 weeks. And she had said, well, she was homeless and it was really stressful to constantly be looking for a place to sleep. And she think that was causing her migraines. And she felt like it was important for the doctor to know that the homelessness that she thought was causing her migraines, and that might help him help her. There was a big push for patient-centered implementation, which meant kind of more empathic inquiry, not box checking. But I think the biggest take-home message is that patients themselves didn't feel like it was healthcare's responsibility to address their social adversity, but rather it should be understood and kind of incorporated into the way they were cared for. And so this ties in nicely to the National Academy of Medicine's framework. So the National Academy of Medicine released this big report back in 2019 about integrating social care into the delivery of healthcare. And kind of in my mind, the big kind of takeaway is this 5A framework, where the middle is awareness, and which is essentially you can't address social needs, you can't do anything about social needs unless you're asking and aware of social needs. And so that was kind of a push towards screening. Assistance is, you know, should we provide direct assistance to patients who have identified social needs? But adjustment is really what the patients were talking about. So how can you adjust your care plan? How can you understand that someone's homelessness or someone's food insecurity or someone's loneliness and social isolation makes it hard for the medical plan to be carried out as prescribed? And we need to make some changes to allow for the social needs to be taken into account. The other two, alignment and advocacy, had more to do with the way community-based organizations are partnering with healthcare and the way that healthcare is really like pushing at the policy and federal level to reimburse social care. But so moving from that onto my last point, I wanted to really focus on where this kind of integration between healthcare and social care is happening. Spoiler alert, it's happening at the state level, and how that's really influencing the partnerships between healthcare and communities. And so how are states incentivizing healthcare to embrace social care? So the answer is, by and large, through the world of Medicaid. So there are some Medicare, mostly dual eligible Medicare demonstration projects happening across the country, but those were kind of carefully selected sites based on applications. What's really kind of happening at the quasi grassroots level is different states are really embracing partnerships with Medicaid to be innovative in the way they're addressing social circumstances for Medicaid enrollees. And so these are kind of the 5 main kind of ways that Medicaid is being allowed to dabble in the social needs space. So I will say the state plan authority on all the way on the left and the integrated care models all the way on the right are functionally the same thing. They're paying for non-clinical care, which in Medicaid parlance is really just case management. So these are 2 different ways to describe case management services of linking patients with social services from within the healthcare system to the social service ecosystem. In the middle, the section 1115 waivers and the Medicaid managed care flexibility, this is more of direct payment for social services at the state level. And I'm going to actually focus a little bit more on the 1115 waivers in the way that they've been using federal funding through Medicaid and then state funding through Medicaid to really fund social services directly. So most of that funding, like if Medicaid is paying for a wheelchair ramp or an air conditioner or medically tailored home delivered meals or rental assistance, a lot of those dollars are actually coming from the delivery system reform incentive payments or DSRIP dollars. I am not going to do a deep dive into what DSRIP dollars are, but I want to show you kind of like the hodgepodge of all states that are trying to use these innovative models to start paying for actual social services, food, housing, transportation, I guess housing abatements and changes to keep people safe in their homes for longer. Of those states, Massachusetts is one of them. And so I'm going to kind of talk through what's been going on in Massachusetts specifically to give kind of like a framework for how that community healthcare partnership is starting to shape up. So the Massachusetts waiver specifically had language in it to require partnership between healthcare entities and social service entities or community-based organizations. And so in doing so, there's been a lot of attention to how healthcare is going to partner with community-based organizations, but there has been very little attention to how community-based organizations are interested in or not in engaging with healthcare in this level of partnership, especially since there isn't a longstanding history of social service organizations being well paid for their partnerships with healthcare. And so along with a colleague who used to be at Harvard, who's now at NYU, we did a large statewide case study to better understand the perspectives of community-based organizations as they were entering into new partnerships with healthcare entities to provide social services for Medicaid enrollees. So what we did is prior to the waiver release in 2018, so this is 2017, we conducted semi-structured interviews with CBO leadership across the state to ask them their perspectives on partnering with healthcare organizations to deliver social services to Medicaid enrollees. We did basic thematic qualitative coding on a total of 47 transcripts and interviews. And then we impaneled an advisory board that included CBO leaders, public health leaders from across the state, and also healthcare leadership who were engaged in these contracts to better understand if what we were finding comported with their lived experience, if it made sense, and was kind of applicable to what they were seeing on the ground. And so of the interviews, this is how they broke down across all 47. You will notice it's a little bit heavy on housing. That is because there was whisper down the lane that the language coming out of the Medicaid waiver in Massachusetts specifically was going to have specific language focused on housing as health. And so we thought there was going to be a bigger push to funding housing interventions compared to some of the other interventions. And then, we did all this coding. We published obviously 3 papers. We have a lot of findings here, but I wanted to kind of drill down in like the central tenets of what we found. So first of all, the community-based organizations in general thought this was a good idea and made a lot of sense. They said, we called it policy movement in the right direction. And so one of the CBO leaders said it's moving in the right direction. This idea of fracturing a person into medical care and social care is ridiculous. It doesn't make common sense and it's not working. People need this service, and it should just be part of holistic patient-centered care. And that was representative of what we heard from a lot of the community-based organizations thinking about the healthcare social service partnership. However, there was a lot of concern about the medicalization of social services and the medicalization of community-based organization work. And what medicalization means is when you take a non-medical problem and turn it into a problem that is treated as if it were a medical problem. And so one of the CBO leaders said, I'm concerned, oh, here, I have to move everyone's picture because you can't read it. I'm concerned that healthcare will want to make this into tight compartments. They'll want to define it. They'll want to encapsulate it. They'll want to put borders and boundaries around it. And it will no longer be a social determinant. It will be a new service line. And so kind of our take-home findings to avoid medicalization, because everyone was excited to get on board with this healthcare social service partnership, but no one wanted to see community-based organizations turn into an appendage of the hospital and healthcare system. And so the first idea was that everyone should get a seat at the table. Decision-making should not be made by the healthcare system alone. Community representatives, decision makers from community organizations, policymakers should all be part of the solution to improve social determinants of health and address more downstream social risk. Second, everyone was concerned about where the incentives were placed. And so they wanted it to make it easier and more desirable to do the right thing, to think about community and social risks, as well as health risks, creating a reimbursement and reward structure that allows for big picture thinking for complex patients, rather than narrow and disease-specific interventions. This harkens back to my Mrs. Y patient where she was dizzy, and it would have been, I was incentivized to order all of the medical tests, but I was not incentivized to help her get more food. So how can we change those incentives to do the right thing? And then finally, investing. Rather than spending money for patient level interventions, scaffolding must be built to improve social determinants of health from one generation to the next. And so current investments, I'm sure everyone has seen a version of this equality versus equity schematic. So current investments in the way we think about social need and social risk look a lot like the equality picture, where we kind of develop a one-size-fits-all intervention for a very specific disease or chronic illness, and then we kind of roll it out to everybody in that specific group. So, thinking about management plans for people with diabetes or health literacy programs for medication management and folks with congestive heart failure, like that doesn't help everyone. It doesn't address any root problems, and it doesn't prevent like long-term like intergenerational health disparities. And so we have to really shift our viewpoint to investment to longer-term healthcare programs rather than short-term returns on measuring A1C or measuring blood pressure. And so developing health literacy programs should not diminish our focus or our commitment to improving public education and universal pre-K, right? Because that will have more intergenerational change over the longer term. And so kind of coming back to this measure, thinking about from government to individuals to healthcare, I really wanted to end my talk with some food for thought about how healthcare and community partnerships are really evolving in the shadow of medicine's new appreciation for social determinants of health, right? And so this is to think through well, what is the role of a community-based organization? Because that's where the actual work of addressing social needs is happening. It's where grassroots advocacy is pushing against policies that perpetuate structural inequities. Community organizations are innovative and responsive and tailored to their communities. And so when they try new service lines and they feel that the community isn't responding, they'll change, but they're not doing it based on data, based on return on investment. They're often providing feedback. So as we kind of enter into this phase where Medicaid wants to collect data and measure return on investment and look at intermediate health outcomes like A1C and systolic blood pressure, community-based organizations aren't really poised to be our partners because of lack of infrastructure and lack of historic ability to do that kind of data-driven work. And so I kind of wanted to end with, what if the idea of how is the best way to do it? How do we go from a narrowly defined chronic disease population to really addressing public health and population health by supporting our community-based organization partners? And how do we do it without setting kind of really constrained parameters and just let everyone in the community use a food insecurity intervention without measuring anyone's A1C? And how can we support the work of community-based organizations without forcing them into a medical model where our success or failure is kind of based on very data-driven midstream metrics? And so with that, I'm going to stop. I hope I didn't take too long. I'm really looking forward to comments and feedback, but I will let Andy take over.
Thanks very much, Elena. And I'm going to just pull my slides up here. thank you very much, Elena, for laying a terrific foundation and framework for this discussion of the whole problem of how we connect the social needs of people and patients to the healthcare system, and broadly how we address the social determinants. And thank you to MPHA and the Equity Committee for sponsoring this event. I think it's really important that this conversation begin to unfold in a more vigorous way. It's already underway in Maine, but it's really important that it expand and that we begin to penetrate parts of the health system and the community-based social service and public health systems in a way that can lead to more action. In addressing the health-related social needs topic today, I really want to acknowledge my co-conspirator, Deb Dietrich. She and I have partnered together on a MEHAF-funded project and produced a report from that project, which I'll have the URL at the end of my last slide that you can access the report. But much of what I'm going to say essentially derives from the work we've done together. And we did that report and that project under the auspices of the New England Rural Health Association and the Rural Health Action Network. The purpose of our project really was to lay a foundation for action. And we were trying to learn from examples across the country of how communities and organizations really have done the work that Elena described to some degree in Massachusetts and certainly around the country, how we could bring that to Maine and craft something that would begin to more actively structure systems that brought these different sectors, namely healthcare, social services, and public health together. I'm going to talk a little bit about the health-related social needs. I think Elena did a great job of sort of in her pictograph describing the difference between the social determinants and health-related social needs. But what I'm bringing to this conversation, I think, is a focus on how we do a better job of addressing social needs in the rural context, and why what the justification or rationale for addressing this in a rural world is particularly important as it relates to disparities and equity issues. And to talk a little bit about the strategies of partnership and governance and payment and financing as a means to begin to address in a better and more effective way the social needs of patients. Again, I'm not going to add much to what Elena has already very clearly described. I would just do a historical point here, which is really this is not this whole issue or discovery, if you will, by the healthcare system of the social determinants, although it's new and reinvigorated, it is really historically dates back to, if not, dates back to the 1970s when Mark Lalonde in Canada really created the framework for thinking about how health is determined by so many factors, environmental and so forth, that Elena described. So this is not a new issue. It's being rediscovered, fortunately, in the current context. And the term whole person care, I think, is just one additional term that we can use that says what we really want is not just patient-centered care, but we want whole person care, where the needs that people who engage with the healthcare system essentially get those needs met, not necessarily by the healthcare system, but through the healthcare system. And that inevitably means they do that in conjunction with or through relationships, the healthcare system's relationships with the world of social services and public health, in a fashion that really is not common in the United States right now. So the question of why we should focus on rural communities and rural populations and the health-related social needs that they present. First of all, we have extensive evidence of rural disparities in health outcomes, expectancy, mortality, infant mortality, chronic disease. There's really a pretty significant rural disadvantage, both in Maine, which has been demonstrated in a number of reports, as well as across the country. And there is some question of whether those disadvantages are strictly speaking rural, because rural really stands in for, as a concept, issues of racial differences and injustice, socioeconomic and other disadvantages among rural populations. So it isn't rural per se that in every instance is contributing, but it is a related and important factor. Achieving equity really is, in a rural context, is going to mean addressing some of these underlying social needs that we have in rural communities that contribute to the health and resource limitation problems that many of us are familiar with if we deal with rural communities. The socioeconomic and demographic characteristics of rural communities and populations in Maine really contribute to very high levels of social need. Compared with urban parts of Maine, rural Maine is older. They suffer higher rates of chronic illness, which, together with high rates of poverty and economic dislocation, food insecurity, and other social needs, really produce those disparities that we're referencing here. In addition to these underlying health and social challenges, the problem of addressing social needs can be really challenging in the context of rural communities, as you might imagine, and perhaps you're familiar with. There's limited availability and accessibility of services in many communities. Community-based organizations in rural communities tend to be under-resourced relative to their urban counterparts, and the urban counterparts tend to be under-resourced relative to the healthcare system, for sure. But another important reason for focusing on, and a more positive reason for focusing on rural communities, is that in some instances, it may be easier to test strategies and models for addressing health-related social needs and the system that you need to do so in the smaller context of a rural community and a rural health and social service and public health system. Rural communities typically have smaller numbers of community health and social service organizations, and they're not competing as much for limited resources, and with the proper incentives and support, may be able to affect collaborations and partnerships that would be harder to do in the urban context. So the question is, how do we transform rural services to align and achieve better outcomes? This is a framework that we borrowed from colleagues at the Georgia State University, who are running a program funded by the Robert Wood Johnson Foundation called the Aligning Systems Project. And it's an effort to essentially define the elements that go into producing, on the right-hand side, the kinds of outcomes that we want to achieve, namely what the community wants, health equity and racial equity in healthcare and health. So you've got the sectors: public health, healthcare, and social services. But the essential elements and their key points here is that those three sectors, healthcare, public health, and social services, really have to be aligned through a series of key elements, namely shared voices and shared purpose, and that those community partnerships that are defined by that shared purpose and community voice, really are the foundation on which to build, transform, and build service systems that actually serve to integrate across healthcare, public health, and the social service sectors. The critical part of the community partnership, though, I think boils down to how those community partnerships ultimately are governed. In other words, how are they structured and how are they governed? And I'll talk about this in a minute. And in particular, dealing with the power dynamics, and Elena mentioned this a bit in her talk, the power dynamics between the healthcare sector and the other sectors can be very difficult and tricky. The various sectors have not always wanted to be in each other's space. And so getting them to work together and to build the trust needed is critical. But in the end, and this is one of my takeaways, and spoiler alert, we're not going to really achieve much more than incremental progress unless we change the way in which money flows in the system to enable and to incentivize the kind of collaboration that will be needed to affect the kind of change that we're looking for. Sorry. Deb and I, in the work that we did for the foundation, put together a logic model, and those of us in public health have become totally committed to logic modeling as a means for conceptually thinking about how we intervene with a problem with a set of goals to achieve an outcome. And I'm not going to go through this. You can peruse it at your own leisure. But I want to focus on the fact on a column of strategies, and in particular, simply emphasize that if we think carefully about what we want to do and how we do it, and I think the Massachusetts examples that Elena talked about were really important. You know, if we think about the ways in which we can create opportunities for collaboration and for more integrated service delivery between healthcare, public health, and social services, we can actually achieve both the intermediate and longer term outcomes that we're looking for. It may start with screening for health-related social needs in the context of a primary care practice, but really we have to think bigger about the service system and its broader functioning in order to be able to achieve the kind of outcomes that we're looking for. And you know, the funding arrangements again are going to be very much critical in this. So Stephen Shortell, and who's a well-known organizational theorist and healthcare and big-time health services researcher, not a rural person really, wrote a blog recently in Health Affairs about what it would take to improve health in rural areas. And I'm not going to read this, but basically he said we ought to be focused on accountable communities for health. Many of us are familiar with those concepts. And he came up with this notion that we develop a rural community health improvement system that would be, in most cases, organized at the county level. You know, it was to me fascinating that somebody who really has spent their time in the healthcare system thinking about hospitals primarily is now thinking about rural communities and how we do a better job of addressing the real needs in rural communities, which are the health needs and not just the health care needs. Thinks about this rural community health system improvement project. So what is it when we talk about rural community health improvement system? What is it and how do we get there? And this is a large part of what Deb and I spent our time in writing about in the paper that we did. And it boils down to building community partnerships, identifying the alignment strategies to eliminate wrong door and wrong pocket problems, and aligning money and financing. And let me just spend a little bit of time on each of those. So as in the framework that I showed from the Aligning Systems project, partnerships are about engaging the voices and the voices from all parts of individuals and organizations across the sectors, as well as marginalized populations that have not typically been part of the conversation, and crafting a shared purpose and a shared vision for what is to be achieved through partnership. Developing a shared governance model, meaning how are we going to operate as a partnership, given the framework and so forth of our vision and shared purpose, and identifying the inequities in the community that we think we can address. Communities can't boil the ocean and deal with every inequity or every problem that exists. Priorities have to be set, and you have to start someplace. But having a systematic, or not systematic, but having a solid framework and structure and governance process is critically important. Foundational to all of that is dealing with the power dynamics and making sure that everybody's at the table with the same voice and an equal opportunity to shape the vision and strategy. I just want to say a few things about the wrong door and wrong pocket problems that we face that are really impediments to dealing with health-related social needs. The wrong door problem we're very familiar with. People in the health system, social service system, public health system, who have various and sundry needs, not knowing where to access the right door in order to be able to get their need addressed. And certainly Elena's clinical example is a good illustration of that wrong door problem. You know, going to the healthcare system to deal with a food problem is probably not the appropriate response. But in that instance, it was addressed. And that's exactly how we want the system to work, so that there is no wrong door. People can come into the healthcare system, social service system, and get their needs met in a somewhat seamless way. The wrong pocket problem is really an impediment for system change, and that is that the healthcare system, all of our financing systems are so siloed. You know, the social service system, the public health system, and the healthcare system, and money flows such that it is very hard for providers in one sector to do things that they don't get paid for. So the healthcare system isn't there to solve food insecurity. It isn't there to solve problems of housing or transportation, and therefore we don't have to pay attention to it. Well, yes, they need to pay attention to it, but we need a financing system that deals with these wrong pocket problems where healthcare providers aren't disincentivized from dealing with the problem just because they don't get paid for it. And so aligning money and financing, again, I'm going to hit this one hard, is really fundamental to dealing with the problem. And we'll talk about that in a minute. I just want to mention that there are other dimensions to this problem and to solving or addressing the problem, which is we've got to work on data and information sharing strategies in communities and among providers and organizations. And we also have to work on workforce. You know, workforce is a fundamental changing sector where we are now employing diverse populations in diverse roles to begin to connect to populations that have particular social needs in ways that are more effective, community paramedicine, community health workers, etc. So what do we know about partnership and governance strategies? First of all, multi-sector community engagement and collaboration is foundational. And as I said, the key elements of that are shared inclusive vision, strong financial and other incentives to bring people to the table and keep them there, and an effective structure, governance, and accountability. And do we know that these are possible? We talk about partnerships all the time as if they are easy to do. The question is, do they work? And I'm going to give you a few examples of places where we visited, not physically, but through Zoom, and learned a lot about their community engagement strategies. Financing and payment. There's a lot to talk about here, and I'm just going to scratch the surface. So we have right now been playing with new models of value-based payment for a number of years, a decade or so, more than a decade, called accountable care and accountable health models. Many of us are familiar with how those are structured under the Medicare program and also under the Medicaid program. There is in theory, mechanisms under those models for healthcare providers in particular. These are being used in the healthcare sector, to think creatively about what services to provide, provided that those services can result in savings to the accountable care organization, such that they pay for themselves, if you will, and are value services. As I've said, unfortunately, healthcare is not being paid in a way that really incentivizes services being provided that are not typically tied to a diagnosis. Medicaid, as Elena showed, is the exception to this. And we've been doing this in Medicaid for a very long time. I should mention that in the healthcare system, there are mechanisms currently for identifying social needs through the ICD-10 codes, but not for paying for the services. And so those codes are not being used. We're not getting a sense of what the volume is of people presenting with social need problems. The Medicaid reform proposals that the map that Elena showed of the states that have 1115 waivers is really interesting. Those 1115 waivers are quote unquote a heavy lift for those states, in the sense that they're hard to get an 1115 waiver. But the range of innovation that's going on under those waivers is truly impressive. And in my judgment, it is something that we should be thinking about in Maine, but that's simply my view. I just want to mention wellness funds. So wellness funds are being used, it's a term that has various meanings, but at the community level, we have initiatives that are trying to create pools of money that enable communities and community organizations to access money to pay for services that are not typically paid through the silos that we typically operate under. They're using, in a number of cases, community development financial institutions, CDFIs, and such as coastal enterprises here in Maine, to help fund some of those initiatives, to invest in new models of care. The Healthy Communities funding hubs are a mechanism that the Trust for America's Health has been promoting. The idea there is to get these community partnerships to create something through which funding models can be created that better align funding with the services that are needed across the different sectors. It's a complicated strategy, and it's been mostly conceptual in terms of how it's been proposed at this point. Braided funding is a strategy that I think we need to think a lot more about and hopefully push on to get better policy support for it. Children's cabinets in Maine and in other states, for example, have been using braided funding concepts to bring services that they're financed in a siloed way together to address children's needs. And at the community level, I think the communities are trying to do that same thing through the community funding hubs that I just mentioned. Community benefit and Maine shared community health and needs assessment. So community benefit laws that require that nonprofit hospitals do triennial community health needs assessments, and which then require strategy plans on the part of the hospital are really important vehicles, probably underutilized with respect to helping us address social needs in the community. Unfortunately, we are stuck on just doing community health needs assessments as an exercise and doing reports, and not on using the process such as that has been really pioneered with the Maine Shared Community Health Needs Assessment to bring social service, healthcare, and other organizations in the community around the table and build a partnership to develop joint strategy and vision for how to address the needs. So I'm running short of time, but I do want to spend some time talking about some examples that illustrate some of these concepts. So one of the communities that we visited with is in Vermont, and it's called the NEK Prosper. That's Northeast Kingdom Prosper Project. This is a project that's of the Caledonia and Southern Essex Accountable Health Community in the Northeast Kingdom of Maine. That's around St. Johnsbury. They've been around for a while, and they've been doing very interesting work. I think they were initiated, or their organizational home, let me put it that way, was really the hospital system or hospital up there and the health center in St. Johnsbury. But they have many partners from the private sector and from social services and other parts of their region. It really is a multi-sector partnership with a mission of improving prosperity. Their vision is not just a health vision. Their vision is that people need to be employed, people need to be, it's a well-being perspective and not just a health perspective. It operates with a formal governance structure, and it participates, importantly, this is, again, a key element of what they're able to do. It participates in Vermont's value-based healthcare payment system, which operates under an 1115 waiver, which means that they are able to access funding to more flexibly address the health needs that present in the community. They can't just fund anything, but they can more effectively connect patients with the broader needs that they have. But I wanted to highlight one feature of what they've done, and this doesn't do their initiative. It doesn't speak to the full range of their initiative, but they've created something called the Healthy Sense Fund, which was really designed to innovate and accelerate initiatives to improve the individual and community social and economic, environmental, and health outcomes. That's kind of the fancy words that they use. But it's, again, this notion of we need some flexible funding in order to be able to address needs that aren't, we cannot address through our siloed systems. One more example of a community health collaborative in Western Idaho. This is a very rural region, 10-county region. And they, through the public, I think under the leadership of both the healthcare sector and the public health sector, have created this collaborative to align the health improvement strategies that the healthcare system and the public health system, and they brought in social service, transportation, and other entities. They created a limited funding pool. This is the one accomplishment they have so far, and developed a playbook of coordinated strategies that the collaborative hopes to be able to use to invest in improving health in the region. This is very much a work in progress. They started in 2019. It's very similar in some respects to the sort of health district model that we have in Maine of bringing in partners into a broader framework. But it's an example of how you can do this in a very rural region without a lot of external resources. They do not have an 1115 waiver, for example. And finally, Yamhill. Yamhill is in the rural region of Oregon, kind of north of Portland, in the Willamette Valley. It's kind of a small farming part of of Oregon, Northwest Oregon. Yamhill is a community that has a community care organization, which is a specific entity created under the Oregon's Medicaid program to manage to be a partner in the Medicaid managed care system in Oregon. They operate, the CCO, which is a formal organization, operates under a full risk community-based plan in the managed care model that Oregon has. But it's not, in most managed care models, Medicaid contracts with one of the national managed care providers. In this case, they created a community-based organization throughout community-based organizations within Oregon to be the contracted entity. And there are requirements for these community care organizations to bring in not just healthcare, but also social service and mental health and behavioral health, et cetera. So the CCO really has developed a broad partnership among the different sectors to operate the plan. And the way the plan works is if the health plan achieves savings, those savings can be put to investments in priority initiatives. That's the incentive for the CCO. And they've done it in a very interesting way, and they have substantial savings on the healthcare provision that they do, such that they've been able to invest in a very interesting early childhood education innovation, working with the school systems in Yamhill. So those are just a few examples, and we have others that we feature in the report that we did, and which you can look at when we're done. So just to sum up here, you know, there are lots of challenges in trying to do this work in rural communities, not just the resource limitations, which we always think of, but the power dynamics which exist everywhere, but which can be pretty brutal in healthcare and community-based organizations in rural communities, and where marginalized populations really have had very little voice, and there's not historically a lot of support for marginalized populations in rural communities. You have historical animosities. Anybody who's lived in a rural community, knows what those are. And we cannot underestimate the importance of the more recent, I think, cultural and political divisiveness between rural and urban that really has, I think, soured the sort of community landscape, if you will, and makes it more difficult. But we have lots of examples in Maine where those limitations and problems are being overcome, and where there are lots of exciting things going on. The bottom line is that we can do incremental things. Yes, we should be doing screening, for example, but we really need to change the systems of care across these sectors. And that will probably require some new financing approaches that we haven't yet seen in Maine. So with that, I will open it up for our discussions, and thank you very much for having me.
Thank you both so much. These were really great presentations, and we're so glad to have had you able to be here and to share this information and learning. And we've definitely had a lot of questions come in, so we'll take a few minutes to do those before we head into our breakouts. And I do ask that people stay on if they're able to. So one of the first questions is, how do healthcare providers even begin to figure out how to prescribe help to patients that the patients can afford and access, especially when there's a wide range of covered services depending on your insurance?
So just to clarify, this is like healthcare providers, like a primary care doctor, a pediatrician, or an OBGYN prescribing social solutions. Yeah, I mean, I would argue that it's not the primary care provider or pediatrician or OBGYN's job to do that. All evidence suggests that patients actually don't want their provider to do it, because there's the assumption that we don't know what we're talking about. And also there's the assumption that the information is used to be part of the medical care provided, rather than as a meaningful first step to get those adversities addressed. And so I think because it is impossible for healthcare providers to really know all of the full scope of social services available, I would argue that it is not a healthcare provider's job to do that, and rather a healthcare provider's job, as intended, is to provide healthcare while being knowledgeable and seeing the whole person in front of them about their patient's lived experience and social circumstance to allow them to provide the best possible care. I don't know if that answers the question.
Yeah, I would just add to that. I completely agree with that. I would just add that if we had a system in which the clinical care provider can turn to somebody in the organization whose responsibility it is to help patients understand their needs and be able to help them navigate to whatever services are available in the healthcare system versus the social service system, and hopefully within the framework where that healthcare system is working with other. I think we do this a lot on the behavioral health side, and it's not really, whether it's behavioral health, transportation, or whatever. It's not that much different, it seems to me.
Thank you both. And this one, sorry, my screen's jumping. This goes to both Elena and Andy, and I think you can read it in the chat too. But Chris is wondering if you can address the role of leadership and the barriers inherent in setting out to facilitate a shared vision, especially if leaders don't or won't get it, and with turnover in leadership and administrations.
Well, I'll just jump in and say that there's no question but that leadership, particularly at the community level and within organizations, is central. Somebody's got to have fire in the belly that says this is important, we're going to do it. And in the examples that Deb and I encountered and investigated, there was always somebody who was championing the issue and who was leading the effort to bring the pieces together and to argue the case to the higher ups that this was an important investment or important thing to do. So leadership at various levels is absolutely essential.
Yeah, I would agree. I mean, I think this is really difficult work because there's not a lot of real alignment of incentives in the way that community-based organizations work versus the way that healthcare organizations work. And so without really dedicated leadership, the hurdles are early and often. And so, and I think in part of Andy's talk, how he talked kind of about how a lot of this work is done in silos, makes it even just the shared language is difficult to kind of come to agreement about what the right course of action is and what a meaningful partnership looks like. And so I would just kind of agree with what Andy said in terms of leadership being essentially essential to the success of any sort of meaningful partnership. And that really, what I'm seeing at the state level through various state Medicaids, both in New York, Massachusetts, Oregon, but there's kind of this carrot stick phenomenon happening to try to get people to really engage, but without real willing partners on both sides, even with state level money hanging in the balance, it's still not gonna work.
Thank you. Any other questions or ones that I might have missed? And folks can feel free to come off mute too if they'd like to ask. Go ahead, Kate.
Thanks to you both. This was just a wonderful session. And this question kind of follows up on Chris's question about leadership and the sort of fundamental challenges of incentives that don't align or that push us in the wrong direction. I'm wondering if there's infrastructures or structures that sort of help institutions and organizations move from that individual level to a more structural level of change that y'all have encountered in your work or in your research, and what are those, right? Because it's not just some bad apple leaders, right? It's people working in incentive structures that don't align. So, but thanks for this great session.
Well, I think having some sort of policy framework within which leadership can be exercise is really important. So there was someone in the chat who was asking, or I think Catherine was mentioning the new primary care reform initiative in Maine. You know, that will create a framework within which leaders in the various primary care specialties and health systems can, you know, exercise their leadership more effectively on some of these issues. Without a policy framework and without, you know, incentives, I think it's hard. It is the, I mean, it exists. Believe me, there are interesting examples, but it's hard for leadership just to pop up and say, we're going to rebel against the world and do their things differently. It's very tough.
Yeah, I would also argue there's like interesting innovation being done in the space where there's a version of this talk. I've had too many slides, but like thinking through like the hub versus spoke role of healthcare and where kind of like where the center of gravity is in these conversations. And so traditionally we see healthcare as like the center of gravity kind of as the hub with like the spokes of the state or social care or community health or public health kind of coming off that with healthcare as the center of gravity. And there's like an alternative model where like the government is kind of the center of gravity and then healthcare and social services and public health and all those things kind of come off the center. But there, I know there's work being done by a colleague of mine where the center of gravity becomes like a third-party contractor, where it's like not the state, which has like all kinds of carrots and sticks, like in terms of financial incentives and reporting requirements. It's also not healthcare, which kind of forces like the medical model of engaging in contracting and measurement and data and outcomes, but rather kind of like a third party that is able to create a more equal partnership between all participants. It was actually written up in Health Affairs back in, I'm going to make up a number, like 2018. And I know it's actually gone live with funding to try to have this like third party hub that does the contracting, that does the measurement. And so it can create this kind of value alignment where it's not like either the state or the healthcare organization, but rather like a more true partnership and stakeholder engaged process in deciding what the contracts look like, what the dollars look like, what the outcomes look like. So it feels like more equal among like all the spokes. And so I think that's a really interesting direction. I don't know if it's going to work because like who is this third party and what does that look like and where is their skin in the game and how are those decisions made? But I think it's an interesting idea. And that, you know, I'm interested to see what the results are of the kind of putting into action the theoretical concept of a neutral third party actor.
I would just say that and there are places that have actually demonstrated, you know, that model of having a backbone to a community partnership that really helps equalize the playing field for everyone. And you know, some of the demonstrations in California, for example, have had that kind of a model. And I agree. I think that's a really interesting strategy.
Thank you. And we'll try to take one more question from Barbara, and then we will stay in the room since we've had some folks drop off and just talk about some action steps before we wrap up. So go ahead, Barbara. It looks like you're muted.
Apologies. I think you just answered the question that I was coming to, but when Elena, when you were first saying, you know, the health system or government is center of gravity, I was saying in my head, do you have to have a center of gravity? Because in fact, a more distributed community model might be better. But I think the examples that you and Andy just gave may speak to a more distributed model. And the other thought I had as you both were presenting is, and one of them clearly is the money. Another one probably is leadership, but what are the critical pieces you've got to have just a model work against really concrete silos that we have, with the health system being one of the biggest. And I'm part of a health system. So anyways, thank you. You've given me a lot to think about. And I'd love to know more about some of the distributed models in California or the one you were referencing, Elena. Thanks.
I mean, to address like, in addition to leadership and financing, I don't know if this is like financing adjacent, but I feel like infrastructure is one of those things that needs to happen because what we find, so I'm currently doing kind of a post hoc analysis of what some of these 11, 15 states like who have engaged in like the social determinants of health contracting, like, well, 4 years later, like, what does it look like? What's the feedback? What's the next step as you kind of re-up your waiver renewal? And what we're finding is that in addition to financing, in addition to leadership, there's this big issue of kind of like infrastructure, and that healthcare just becomes this like 10,000 pound gorilla that has the computers, that has the IT, that has the community health workers. And that because the community organizations or the social service organizations like can't keep up in the ways that like data needs to be collected or in the volume of patients that need to be served, what we find is that even if the intention isn't for healthcare to completely eclipse the social service organizations, that like the intention was an equal partnership, the intention was kind of stakeholder engaged outcomes, what ends up happening because of that disparity in just capacity and ability, like independent of financing, because like financing is obviously a part of that, is that it just becomes unequal and difficult to initialize. And so I think there's now a lot more attention being paid to that with like technical assistance dollars and kind of upstart dollars. But I think like dollars alone won't do it. Like it's very hard to kind of build a classroom for, early Head Start programs. And you don't just need dollars, you need trained professionals, you need parents who have access. And I think there's a lot of kind of short-sightedness on like, well, if we just give you an extra check, like you'll be up and running. And there just often isn't that kind of technical finesse and capacity that's equal amongst organizations.
So I would just mention that Deb and I, when we, apologies, I'm losing my voice apparently. Deb and I really wrote the paper that we did in the hopes of incentivizing or framing a demonstration. And so, we kind of laid out in that demonstration proposal the need for infrastructure, as you're saying, Elena, and the need for technical assistance, because these things don't happen simply by saying that they're going to happen. People getting together around a table and talking is not building something in the community that's going to be sustainable, and it's going to have a broader vision than just having a few meetings. So it is really hard work, and infrastructure is a critical part of it. And if you actually get going in terms of information sharing and workforce development and the rest, all of which is needed, you've got to have a capacity to support that. And that's going to take dollars.
Thank you. And I don't want to end the Q&A. So we will take one last question from Chris, but as you know, the title of our series is Moving from Information into Action. So it would be great if folks don't mind thinking of some actions they might take as themselves or within their organizations and adding those to the chat so that we can collect some of that information. And Chris, go ahead and ask your question, and then I think we'll wrap up after that.
I think she hopped off.
Yeah.
Oh, there she is. Okay.
Hi. My question that I put in the chat was different, but Elena, it was for you, and you can just read it. And it was more of a comment. However, I think collectively, having worked in and had the experience of working with the development of healthy community coalitions in Maine, and then the Healthy Maine partnerships, and later the districts, I couldn't agree more with the issue of infrastructure. And we probably need a word that can disguise the notion that what we need is a process person who pays attention to process and who provides technical assistance in all sorts of ways. What do you do when your coalition leader doesn't share the information you've sent with any of their board members? I mean, it's a small problem, but you've really got to think it through. I experienced more myself resistance from my colleagues. I can remember once making a comment that if we decided to do this outcome would occur that would not be productive. And somebody said, well, that's nice to hear your philosophy. It was like, you don't have any idea how much, you know, training and experience I have that behind that message, that garbage in, garbage out. And so whether we call it infrastructure or technical assistance or process, whatever, and I think John Auerbach has mentioned this and other people have said there needs to be someone or something devoted to helping nurture these connections. That's all I wanted to say.
Thanks, Chris. And Elena and Andy, do you have any final closing thoughts that you'd like to add in the last minute or so?
The only thing I was gonna say is, Chris, my upstream downstream slide was taken from a John Auerbach blog post on the Health Affairs website, the Health Affairs blog. So yes, I'm familiar with his commentary. It's just kind of an abridged version for the talk, but thank you for knowing their source material.
So I would also mention, and this is by way of a promise for the future, that Deb and I have discussed the fact that we have just an enormous library of resources on the topics that we've explored in the paper that we did. And we are looking to assemble those in some more meaningful fashion to make them accessible to people. So, and there are a lot of things from Trust for America's Health and other sources that are out there on the web, but we've put them together for ourselves, and hopefully that we'll do it for others.
Thank you both. So we have just a couple minutes left, so we will wrap up. For those of you who are still on, please take our post assessment. And I also included a link a little earlier in the chat to MPHA's event page, so you can find more of our health equity series webinars listed there, as well as our other events. And toggle over to, we're hosting our spring awards ceremony on Tuesday, and would love for everyone to attend to honor our public health colleagues. I want to say a special thanks to Elena and Andy for being here. We really appreciate you taking time in your afternoon. This has been great information. Thank you to Kate and the University of Maine Augusta for co-sponsoring today. And many, many thanks to the members of our health equity member section for developing today's event. And thank you all. And I'll be following up with a recording and some of the comments from the chat. So thank you all so much. Have a great afternoon.
Thank you.